Marhaba, everyone. I think we have a small group, but I'm sure it's a very distinguished group. And it's nice to see friends here and some new friends. So I'll go ahead and get started. I'll be talking about the Psychopharmacology Algorithm Project at Harvard South Shore Program. It's an update on management of behavioral and psychological symptoms in dementia. Start off with some acknowledgement and disclosures. I'd like to thank all my co-authors and mentor, Dr. Osser, who happens to be here today. None of the authors of the paper of which this lecture has anything to disclose. We're all academically affiliated with Harvard Medical School, at least at the time of publication. Some of our co-authors have moved on, but I've stayed. So first we'll start by talking about how you might want to think about cases with behavior and psychological symptoms of dementia, which moving forward I'll call BPSD. I think it's important that I make the distinction between BPSD and NPS, which is neuropsychiatric symptoms of dementia. You will hear both terms if you are kind of in this field. We'll talk about why do we care. And lastly, we'll kind of go into the meat of it, talking about treatment from a pharmacological perspective. There are some new medications that are coming out. I might mention them briefly, but we'll kind of stick with the ones where we have a lot of the evidence already. So to start off, I think if you treat older adults, you know when they come in, it's frequently a mixture of multiple organ systems. There's a lot of presentations coming out. You look at all the symptoms. You have to first decide what the diagnosis is. Frequently, there's going to be a lot of competing diagnoses. You as the physician, you have to decide what is the primary diagnosis driving the presentation. If this is BPSD, then this is the algorithm you should use. But if you just stick to trying to treat the symptoms, you will get lost pretty quickly, and that probably won't end well. In older adults, it is the exception rather than the rule to have only one diagnosis. So that's why you want to be thinking about comorbidities at all times. So this is kind of what I'm talking about. You want to first aim and then fire. You don't want to just ready, fire, and then aim afterwards, because you could miss pretty badly. After you've decided your target, you go after it. You want to make sure you have a way to measure the treatment outcome. It's better to establish that firsthand, because sometimes when you're treating BPSD, patients may not feel like they're getting better, or families may not feel like they're getting better. But if you have the treatment outcomes that you want to measure laid out beforehand, you might say something like, oh, wait a minute, but actually you're sleeping better. You know, everything else is similar, but you're sleeping better. So it's nice to have some treatment outcomes. So this is the paper that was published in 2021, so it's really recent. So let's start. What exactly is behavioral and psychological symptoms of dementia? The meaning is kind of within the name of itself. It's a collection of symptoms. You have screaming, calling out, verbal and physical aggression, agitation, apathy, sexual disinhibition, defiance, wandering, hostility, and paranoid behaviors, psychosis, and mood disorders. The ones that are bolded, you see them most common clinically, and you frequently will have a mixture of all of these different symptoms. If you're looking at these presentations, you might think this looks very similar to a very emergent situation where a patient might be presenting to the ER and they're actually in the context of having a urinary tract infection. That's kind of true. But I would argue that BPSD is really almost like a diagnosis of exclusion, meaning you want to make sure that there are no underlying medical causes driving it. Because if there is, The technical way to treat delirium is you treat the underlying medical cause, and then you support the patient through. It's pretty true that while you're supporting the patient through, some of the logics and things I will be talking about here is still relatively translatable. So let's first get some definitions straight. So we have BPSD, which I talked about, behavior and psychological symptoms of dementia. And then we have NPS, neuropsychiatric symptoms of dementia. A lot of recent publications at the American Journal of Geriatric Psychiatry refers to the term NPS. So NPS, by definition, are all the non-cognitive symptoms related to patients with dementia. And it doesn't, same is true with BPSD. It doesn't matter what the dementia subtype is, it's an umbrella diagnosis. So we want to remember, and this is something that I'll go back to again and again, dementia subtype is important. You have Alzheimer's dementia, you have Parkinson's dementia, you have Lewy body dementia, you have frontotemporal dementia, you have vascular dementia. You may have a combination of those, and you have other even rarer types of dementia that I won't get into in detail. So that's something you want to be thinking about. So NPS is frequently thought of as a more inclusive term because they think it reflects the underlying pathology of the disease, which is that of dementia. In the literature, really, BPSD have referred more specifically to the agitative symptoms of dementia, which are like aggression, screaming, and acting out. But really, I've talked to a lot of experts in this field, including Rajesh Tampi, Brent Forrester. A lot of them feel like BPSD and NPS could be used interchangeably. But really, BPSD is used mostly in Europe and NPS in the United States. And it's my personal belief that these classifications and definitions will probably continue to evolve, so we'll kind of keep an eye on it for now. But for now, at least in my mind, they're interchangeable, and I think it's a pretty safe assumption. So why exactly is this clinical problem important? Well, dementia, and I really think this is like an underestimation, affects 5 million adults over the age of 65, and is projected to affect 3.3% of the population by 2060. The reason the training for how to treat BPSD is important, because you want to be able to identify it early. Otherwise, the patient prognosis becomes poorer and poorer as you let the BPSD rage on. There could be an accelerated decline in cognition and the quality of life for the patient. And it's truly a leading kind of cause for caregiver burden, and frequently becomes a reason patients are admitted to nursing homes or kind of a higher level of care. I don't know about you guys, but most of the patients that I treat, they prefer to live in their homes and be with their loved ones for as long as possible. If they do have to leave their homes, they kind of wish it's on their term. Many times patients come to me and I actually spend 10, 15 minutes towards the end talking to the family to make sure they're doing okay. Especially if the BPSD is still very thick, because I know the caregiver is probably really tired. Of course, there is a time when escalation of care is appropriate, because if the caregiver cannot take care of themselves, they cannot take care of the patient. But that's a talk for another day. And many of you guys may know that there are now these disease-modifying agents on the market, such as the Eisai and Biogen's result on lecanemab. We don't really know exactly how this will shape this field, in the sense that you might create a lot more patients who have dementia, but it just doesn't progress to severe disease. So it's an entire possibility that the amount of patients we're going to see with BPSD, maybe in the kind of like the earlier stage, could really increase significantly. So what do we do in this review? So basically, we updated Dr. Osler's algorithm in 2013. We searched new studies and reviews published since the beginning of 2018, because there was another review that was done considerably well by Davies' team in Canada. What we kind of want to stress in our algorithm is that when you treat patients with BPSD, it's really an individualized approach. You have to figure out what the patient's goals of care are, what the family's goals of care are, and try to tailor it to that because they have to be on board for your treatment to actually be successful. Non-pharmacological approaches are really important. They should be in the forefront of how you're going to be treating your patients. You should be constantly thinking about these approaches, but we just don't talk about them in our algorithm because this is a pharmacological algorithm. I'll leave it at that. So the way we think about BPSD, and this is kind of novel for our team compared to others, is that we break it down into emergent BPSD, urgent BPSD, and non-emergent. So let me kind of clarify what that means for us. So in emergent BPSD, the clinician, patient, or others around the patient are in imminent danger due to behaviors related to BPSD. So let me give you a lot of real-life examples. I had a patient who was in his 80s, Asian, taking a knife, threatening to kill his wife every other day. That's emergent. If you don't do something, the patient or the wife will end up in the hospital, or both. Urgent BPSD is that the patient is in distress, but there is space for a few days to weeks for improvement. So let me give you another real-life example. This is a patient with Parkinson's dementia. Every day between 3 to 6, when her wife is not yet home, she used to be a police officer. So she would go around the neighborhood doing wellness checks on others because she thinks she's working, and then she could get into conflicts. She may lay outside in the ground just crying. You want to do something pretty quickly. This is not something you can let it sit. You maybe have a few days to a week to get things under control. And then you have non-emergent, where the patient does not appear to be at imminent risk of putting him or herself or others at harm. So I'll give you another example. I have a patient with frontotemporal dementia, and probably a mixture of vascular, but he just doesn't care at all. He also happens to have many daughters. Whenever he comes to the clinic, he won't say anything. The daughters will do all the talking. And then he does what people tell him. He seems really sad. There's nothing urgent. Like next week, 2 weeks, he'll probably still be at his home. But for the wellness of the patient, you do want to do something. You have a few weeks to a few months to try to make a change for the patient. And this timeline is really important in your mind because the medications that we use have a specific timeline for when you can expect to start seeing a change. And you'll notice when I talk about my patients, I actually know the dementia subtypes very clearly in my head because that's pretty important. When we look at emergent, urgent, or non-emergent, clinically they're really fluid, meaning as you treat the patient, they go from emergent to urgent. You shouldn't be surprised if all of a sudden they flick back from urgent back into emergent. Ideally, they keep going from emergent, urgent, to non-emergent, but things are going to be fluid, unfortunately. So this is just the method section on the different terms that we looked at. And in totality, 231 articles were selected for review. I'm just gonna have a sip of water. So what I'll do is I'll go over the notes, and then we'll go into each specifically, all right? So let's say you diagnosed emergent BPSD. You made sure that there wasn't other underlying medical causes. What do? So let's go back to my patient who was Asian and having a knife and threatening his wife. At that time, what do you think are the chances you say, hey, do you want to sit down? Let's take this medication, here's a glass of water. Probably not. You might get swung at. So we assume that oral medications are not feasible in these situations, and you do need to try intramuscular injections, such as olanzapine. If you do not see an adequate response, you might try intramuscular injection of haloperidol. Now, if your patient is at home or at an assisted living facility, frequently, this is not exactly feasible, so at this point, they actually might be in the hospital. So just something you want to be thinking about. If there's no adequate response, you might try intramuscular benzodiazepines for short-term emergent situations. And then we hope after you've done these steps that you could transition your patient into kind of the urgent algorithm, and then we can kind of go from there. So let's kind of dive into each one specifically. So the first, our recommendation is that of olanzapine, 1.25 to 5 mg every 30 to 60 minutes, up to 3 doses a day. I will talk about this later, but I'm just going to stress it now. We do not recommend olanzapine outside of this situation, outside of an emergent situation. And the reason is because the metabolic and anticholinergic side effects are really, really strong. Frequently, what you will see is that maybe under different pressures, hospitals really need to get the patients well quick, gave them olanzapine. He started sleeping well, because this is pretty anticholinergic and sedating. The patient gets better in like 2 to 3 days and then comes out. In a week, he gets more confused. In a week, symptoms are back, but actually much worse. And frequently, this is because of the anticholinergic side effects. And what you will hear is that dad or mom is really, really sedated and now falling. Anticholinergic side effect. But it is pretty effective acutely, and that's why we do use it just to calm the patient down. Our previous first choice, aripiprazole intramuscular injection, is no longer available, so that's why olanzapine is our choice. We do want to note that olanzapine has an increased risk of cerebrovascular adverse events compared to that of other antipsychotics. Of course, antipsychotics all kind of have an FDA black box warning, so you do want to warn your patients about that. We're basing this kind of suggestion on a retrospective chart review of 85 inpatient BPSD encounters, and I do like that because context is important. Inpatient means the patient is at the hospital right now, so this is kind of the context where you might encounter a patient who's likely to have emergent BPSD situation. You did get a favorable, in that study, they had a favorable response with IM olanzapine in 63% of the patients, and 41% adverse event of significant somnolence and cardiovascular instability. That's great. Let's put that in context. That means 100 patients, you gave IM olanzapine, only 63 of them will respond favorably. So you shouldn't be too discouraged or shocked if it doesn't work and you have to move on. If you know what the adverse events you're looking for, you can play it to your advantage. Let's say you just gave the first dose, let the patient sleep it off, let the staff know what to expect. They will all appreciate that, I'm sure. The second note, if olanzapine doesn't work, you can certainly try haloperidol. There's a limited amount of studies available. It seems comparable to IM olanzapine in the emergent BPSD setting based off of 2 emergency room studies. So again, I like that because it's in the correct context. Of course, long-term use is not recommended. IM haloperidol 2.5 plus IM midazolam 7.5 seems comparable to IM olanzapine 10, but with fewer side effects. I feel like at this point, a lot of it is different hospital settings. They have my preference. They might have preference. They might be really used to giving IM haloperidol, and they would just like to use that because they all know what to expect. I think that's fine, in my opinion. Then you have benzodiazepines. Again, we usually avoid benzodiazepines in the treatment of older adults in general, unless they really have like panic disorder or something that really warrants the use of benzodiazepines. And the reason is because it can be associated with falls, impaired cognition, at least acutely. I know chronically that's kind of in debate, but acutely I don't think anyone would argue there's an impairment of cognition. And you can worsen the BPSD exacerbation, and I'll tell you why. You give benzodiazepines, which works on the GABA receptor, it will work acutely, but then afterwards the patient will go through withdrawal. So when that withdrawal comes out, it could be confusion, it could be anxiety exacerbation, it's hard to predict. And that's why we recommend here for short-term use in the emergent situation, or if you have a special situation such as the patient has Parkinson's disease dementia, Lewy body dementia, where they would be much more sensitive to the dopamine blockade effect of these medications leading to movement issues, or if they have recent neuroleptic malignant syndrome. So let me give you an example of how I use this. I had a patient who had a fall and really needed to get a brain MRI to make sure there isn't a bleed. In this situation, yeah, I think it's really appropriate to give the benzodiazepine, sedate the patient, get the brain MRI, and then move on. So in these situations, I think it is very, very reasonable and appropriate to use it. Like I talked about, you want to be thinking about the rebound effect. How do you think about that? Think about the half-life of the medication you're giving, and that's kind of when you can expect it. We recommend lorazepam, and the reason is because it's easy to dose, the way that it's metabolized. It's 0.5 IM every 4 hours, maximum dose of 2. If the patient is on any kind of respiratory depressant, you want to be careful, such as olanzapine or even alcohol. So let's assume you did a great job and the patient is no longer in an emergent situation and has now kind of progressed to the urgent algorithm. What would you do? Well, you first diagnosed it, urgent BPSD. If the patient's not recently on a dopamine receptor blockade, you try aripiprazole to a maximum dose of 15, and we'll go into all the details. If you don't have the response that you would like, you might try risperidone with a maximum dose of 2 milligrams. If you don't have adequate response, you could try prazosin with a maximum dose of 2 in the morning and 4 at night. If you don't have adequate response, then you might consider unilateral or bilateral ECT. So let's get into it. First, let's start with the medications you want to avoid in BPSD before we go into all of this. Olanzapine we had talked about. Significant metabolic and anticholinergic properties. I had talked about the anticholinergic properties previously, but why do you care about the metabolic properties? Some would say, do you really care about the metabolic property? Do you really care about the lipid profile of someone who's 79 or 82? I would argue yes, because there is a type of dementia that's very common called vascular dementia. If someone already has Alzheimer's dementia or Parkinson's dementia, you don't really want to be giving them more and more cerebral kind of vascular burden. In a 12-month retrospective cohort study with 133 patients with Alzheimer's dementia, the results show anticholinergic cognitive effect is worse than that of benzodiazepines. It's very true clinically, and a meta-analysis of 3 trials showed it without benefit for BPSD treatment. If you're in a hospital setting where knowing the dementia subtype is just impossible, or very, very difficult to do, then you should just assume the dementia subtype based on what you're seeing and epidemiologically what is most likely. So if you don't see very significant tremors, most likely is Alzheimer's disease. So that is kind of like a decent baseline to use. Seroquel, or quetiapine, 3 studies, 2 were done at nursing homes, show it does not beat placebo for BPSD treatment, and that's very, very true. The 4th study showed the CGI score improvement without dose relationship. So meaning a lower dose and a higher dose, one doesn't necessarily beat the other, so that kind of calls into question. And the standardized mean difference was 0.03 to 0.16, so that's very, very small. Our neurologist colleagues would rightly note that within the context of Parkinson's dementia, there is decent evidence for the use of quetiapine. So in those cases, you might use it, but overall BPSD, the evidence is very, very low. And frequently, what you will see clinically is that quetiapine might work for the first couple of months. As the disease progresses, the brain is much more sensitive to the anticholinergic burden. The patient will eventually become more confused, and a switch to some of the medications that we recommend is clinically what I often will have to do as I get these consults for very complex BPSD cases. Benzodiazepines we had talked about, cognitive impairment, something you want to be thinking about, and there's certainly a very high increased rates of falls. In your mind, when you're seeing the patient, you have to think about how the patient's ambulating. Is the patient walking? Does the patient use a walker? Is the patient in a wheelchair? That will all change how you think about the rate of falls. Is the patient coming alone versus the patient has a whole family coming with them? That all changes your risk calculations when you're thinking about something such as the rate of falls. Valproic acid is another medication we don't recommend. In a 24-month multi-site randomized control trial, is shown to be not effective It causes drowsiness, increased rates of falls, and loose stools. Now, I want to be very clear. We're talking about purely BPSD. So if your patient has a history of bipolar disease and now has BPSD, that is kind of a different situation. And you will see that fairly often clinically where you have competing diagnoses. But here I'm talking about purely kind of within the context of BPSD. Okay, so let's talk about the first medication that we think highly of, and many other countries do too. Is the use of aripiprazole. It's supported by a systematic review and a meta-analysis of 17 studies concluding aripiprazole has the optimal combination of safety and efficacy for BPSD treatments. The American Psychiatric Association guideline found modest effect size for aripiprazole, similar to that of risperidone, which we think highly of as well. But they believe that the aripiprazole side effect profile is milder. There's particularly less fatigue and less kind of EPS symptoms, which is related to kind of muscle movements that we care about. The recommendation, you could start 2 to 2.5 milligrams daily, target dose of 5 milligrams at 2 weeks, increase 5 milligrams every 2 weeks, maximum dose of 15 milligrams. I will make sure I talk about how to dose. The partial dopamine agonist effect of aripiprazole is something you want to be thinking about, and this is why. Frequently, patients have been on other antipsychotics. They've been on dopamine blockade. So you could imagine when your body's on a dopamine blockade, it will naturally try to counteract that by being more sensitive to dopamine. Aripiprazole is a partial dopamine agonist. So your body is now more sensitive to dopamine, and you have a dopamine agonist. So that property of aripiprazole is going to be amplified. And that's why you could see kind of more of the activating effect of aripiprazole. And this is based off of a lot of case studies, case reviews, and that's kind of what they found. For that reason, frequently I don't get to use aripiprazole because when patients come to me, the primary care physicians or other providers have tried really hard, and frequently in the things that they've tried, it includes the use of antipsychotics. How long should you wait? I don't know. Common sense tells me you want to wait at least for kind of five to 6 times of the half-life for the medication to be out of your body, but this is a receptor change, so it likely will be even longer than that. When I'm dosing, what I typically do is I give the daily dose, and then I let the patients have a PRN, and then based off of how they're using the as-needed medication, it gives me a guide on how and when I should bump it up. Meaning, if the patient has been using the PRN daily, then you kind of know it's time to bump it up. Versus they're rarely using it, you might be fine holding. So let's say this doesn't work. Then you want to try risperidone. It's approved for BPSD treatment in Australia, United Kingdom, and aggression and psychotic symptoms in Alzheimer's in Canada. Which is really kind of a subset of the presentation of that of BPSD. It's well supported by a systematic review, a meta-analysis, and 4 positive randomized control trials. The initial dose is 0.25 to 0.5. You can increase by 0.5 daily to a maximum dose of 2. I will say frequently I dose it at night as opposed to in the day because it still is sedating, so I'd rather give it to the patient and they can sleep well. Sleep is really important in patients with BPSD. You want to make sure they're sleeping. It's really tolerable for the most part. It's not super sedating, and it leads to fewer fall risk. And you can see improvements as early as 1 week, and I'll tell you clinically, I see improvements like within days. You want to note that it is associated with compromised cardiovascular health, so if that is a concern for your patient, this is something you want to talk to them about in addition to just kind of the baseline warnings related to antipsychotics. This may not be the medication of choice if your patient has a dementia subtype that's particularly sensitive to extrapyramidal symptoms, and I'm sure your neurology colleagues will get really upset if you try it. But if they had failed what they would like, such as quetiapine, then I think it's fairly reasonable to transition over to risperidone. And I do that, and the results are usually very promising. The next medication we would try is, or recommend is prazosin. It's supported by 2 clinical trials done at University of Washington. in their VA over there. It's only studied in non-emergent cases, but results were seen in the first week, which matches the timeline and what we're thinking about for emergent BPSD. So it's really worth considering at this point in the urgent algorithm. In the 2009 study, they had 1 milligram at night increased to a maximum of 2 milligrams in the morning and 4 milligrams at night. They increased every 1 to 2 milligrams every 3 to 7 days. The study lasted 8 weeks. In the 2015 study, they showed 4 milligrams twice a day for 12 weeks was effective. This medication is particularly helpful if your patient has trauma, PTSD. Of course, if the study is done in the VA population, most of them had trauma, so you would imagine prazosin probably worked well. I'm sure they controlled for that. But trauma is actually really common in older adults. They probably coped it well when they were younger, they were working, but now they're retired. And dementia frequently gives you a sense of helplessness, very confused, and that could be very, very triggering. And a lot of the traumas that they thought they had under control actually resurfaces. Medical PTSD is also something that's very common in older adults. So prazosin does work well. You don't want to write it off very easily. Of course, if they're on a beta blocker, which a lot of them are, then this might be a tougher medication you want to be thinking about. But if they're not, I would try it. And sometimes it also really helps with waking up frequently at night to use the restroom, which is a very common problem for older male patients. So that's also really helpful. The next recommendation is the use of electroconvulsive therapy, ECT. We kind of believe at this point, after you fail so many things, it's kind of worth giving ECT a try. The case series had demonstrated the effectiveness and relative safety. 16 patients with average age of 66 underwent bilateral ECT treatment with improvement. The main concern was post-ECT confusion that you do see often clinically, but it really goes away within 2 days. And I've talked to my colleagues at McLean Hospital, because I don't give a lot of ECT myself, but that's kind of really true. The confusion does go away pretty quickly. I know it's a little bit hard to imagine someone with dementia getting ECT and not being confused afterwards, but it's kind of true that the confusion doesn't last that long. And I would argue if you don't treat the BPSD, the confusion will last much longer. 60 patients treated with ultra-brief right unilateral pulses of ECT showed effectiveness after 3 sessions and sustained through the 6 ECT treatment. The catch is relapse is very common after you stop ECT. So what I would, they'll say, oh, so what do you do? So this is what I do. You, of course, first try the unilateral ones because there's less side effects. And as you're kind of up titrating, eventually going to bilateral ECT, you kind of bought yourself at least 1 to 2 months' time. During these 1 to 2 months' time, what you do is very crucial. You want to optimize all the other factors that are contributing to the patient's presentation. Let's say there's a depression, there's an anxiety component, which I'll talk about later. You start the medication for that, which we know will take 4 to 6 weeks for you to see something. If there are other kind of non-pharmacological factors that you can work on it. Tell the families to work on it while they're getting these treatment. If you've optimized those, then you've created the space to maybe think about a taper. Because when you taper the ECT, you basically kind of span it out slowly and then you stop it eventually. Then you can try. While you're going through the taper, if there's worsening, you're really kind of in a gray zone and you might have to step it back up, keep optimizing, and then try again. So it's kind of that dance that you're going to be engaging if you're at this point. So let's say you did a really, really good job and you went from emergent to urgent and now you're kind of in the non-emergent setting. What do? The first node and the second node you kind of do all the time. You decrease the anticholinergic load. You look at all the medications that they're on. Do you really need this allergy medication that you're taking? Or could you just use Flonase and do it consistently for a while? Are you in pain? How is that pain working for you? Older adults will frequently say, oh no, doc, I don't have pain. I'll be like, really? And then you kind of ask them a little bit more. Does it hurt when you walk up the stairs? This and that. A lot of them have pain. I know this because my mother and father-in-law recently moved in with me for 2 to 3 months, so I've seen it. They have pain very frequently. You want to make sure they're sleeping well. And if they're not, you might consider trazodone. You want to initiate donepezil and memantine. We'll go into the details of that. You don't have adequate response, you can try SSRI, such as escitalopram and sertraline. You could titrate escitalopram to 10 milligrams or sertraline to a maximum dose of 200. You don't see your adequate response. You can try the last kind of antipsychotic that worked in the previous algorithm we had talked about. You don't see an adequate response, try the prazosin again. And lastly, you could try carbamazepine. So let's talk about the anticholinergic and pain control. The cholinergic system is a system that unfortunately starts to deteriorate as we get older. And patients with dementia are very, very sensitive to this. Let me give you an example. I had a patient with frontotemporal dementia. I tried to give him something for anxiety, but the anxiety was really bad that he never got the chance to pick up the medication. He took hydroxyzine, which is just like an allergy medicine or sometimes an anxiety medication from his wife. Took it for 2 days, couldn't pee, got very confused, sent to the hospital. So these kind of anticholinergic systems is something you want to be very, very sensitive about. If the pain is not well controlled, it could lead to confusion. Pain is kind of deliriogenic. So you want to make sure the pain is well controlled, whether that's seeing a pain specialist or not. If it's a really kind of long wait, you could think about some of the other medications we're going to recommend in a little bit that would help with pain. In a 5-year period, 85% of patients with dementia will experience substantial pain. Next is sleep optimization. Poor sleep is associated with worsening cognition. I also know this personally because I have a 19-month-old daughter, so sleep deprivation is very, very common for me, and it does impact my thinking. So you can imagine what that impact will be for someone who's in their 70s and 80s. It impacts attention, and they're more likely to develop BPSD. If you treat the sleep most of the times, the symptoms will get much better. Trazodone is largely a histaminergic antagonist with some cholinergic agonist properties, so we really like that. You can use 12.5 to 25 milligrams at night. The only minor issue with that is if you use 12.5, you have to cut that tablet into quarters, which is hard to do. My grandma, who's 91, does it, so it is doable, but just something to think about. Trazodone is more efficacious than haloperidol in the presence of mood symptoms, so something to note. In a 12-week study of 31 patients with frontotemporal dementia, trazodone improved BPSD symptoms more than that of placebo. But you do have to remember that trazodone has a salient fall risk and is very similar to that of benzodiazepines. What is different, though, is that you wouldn't necessarily get used to the response from that of trazodone. While if you use benzodiazepine for sleep or anxiety, your body will get used to it. You will have to push up the dose with time, and eventually the patient won't do well. But trazodone, you don't really run that risk. Donepezil and memantine, especially memantine, if the dementia is categorized to moderate to severe, that's of course based off of their ability to do daily activities living and their cognitive status determines moderate to severe, they might get to use memantine. They're both FDA approved for cognitive impairment of Alzheimer's dementia. Cholinesterase inhibitors can delay BPSD onset, that's why we like it. When we give this medication, you actually don't expect it to impact the current presentation, but the point is you will prevent the next kind of BPSD exacerbation, and that's why you would want to use it. You would only stop it if it's really not tolerable. So let's say the patient's having really, really vivid dreams, and that's making them really afraid to go to bed. Then in that context, it might make sense to pull it. You can start in close succession. There's a possible synergistic benefit. Donepezil can be used in Parkinson's disease and Lewy body dementia as well. So if your patient is not already on this, certainly consider adding them, and the administration should really be ongoing unless you know it's worsening the BPSD symptoms or worsening the sleep quality, such as kind of like the vivid dreams that I had mentioned. Next, you could consider SSRIs such as escitalopram and sertraline. And most of our evidence come from the CIT-AD trial, which showed that 30 milligrams of escitalopram improved BPSD symptoms in non-depressed outpatients with Alzheimer's dementia. Pollock and colleagues had 3 trials in 1997, 2002, 2007 that showed that escitalopram really works. And you give it 9 weeks, you get full response. There's an issue, which is that there is an FDA warning for the maximum dose of escitalopram, which is that of 20, because of QTC prolongation. And this is a very real issue. If your patient so I frequently get patients on escitalopram 20. They got a little bit better, still depressed or still anxious, but I can't go up because the QTC is 500, 510. So what I end up doing is I have to kind of down titrate or cross taper to escitalopram, which is the enantiomer of that of escitalopram, but you don't have that QTC concern. And the reason I like escitalopram is also you get the effects pretty quickly. It's a pretty good titration, and is relatively well tolerable. We recommend starting at 10, but frequently what I do is I do 5 for a few days, and I go to 10, and then 15, and then 20 if I need to. Another medication you could try is sertraline. It doesn't have significant QTC concerns, and the Cochrane reviews show it is very helpful for BPSD agitation symptoms. Certainly, if your patient, let's say, has a history of depression and responded quite well to sertraline in the past, I would just use sertraline right away. So that is also a pretty nice guide. If the BPSD symptom remains uncontrolled, you would certainly want to consider resuming the last kind of second-generation antipsychotic that worked well for the patient, or follow the oral SGA medication recommendation in the urgent algorithm that we had talked about. Next is prazosin. Here, I don't have too much to add other than the data that I had mentioned previously. I will say when you give the prazosin, you want to know their baseline kind of blood pressure blood pressure levels, because if there is an elevated blood pressure at baseline, that's actually a positive predicting response to how they will do on prazosin. You want to make sure that they're tolerating the medications fine. What I frequently do is I do 1 milligram increase every 3 days or so, and if they're not tolerating, let's say they're feeling a little bit dizzy, they can pull back, wait a few more days, and then keep going up. I see so many times people give up on this medication because they're going exactly as textbook, and sometimes that's just too quick for patients, because older adults, the presentations are very varied, so some could be sicker. And I actually met Dr. Wang, who did the study, and they do use this medication quite a bit, and it works quite well. Last medication on our list is carbamazepine. We kind of put it up here, at least for me. I don't know about Dr. Osler, but I put it a little bit reluctantly because there is a lot of drug interactions, liver toxicity, agranulocytosis, hyponatremia, requires hepatic enzyme monitoring, as well as white count monitoring. So there's a lot of monitoring, and you could imagine that's incredibly difficult for the patient with dementia or for the caregivers and families to kind of bring them to the hospital. So that's something you want to be thinking about. It's supported by 2 small studies with positive results. Given the side effects and the small evidence, we think it deserves to be near the bottom of consideration, but other reviewers kind of put it higher on the list, like the team in Canada. The recommended starting dose is 100 daily. If they're frail, you could start at 50. Let's talk a little bit about the medications that are out there, and it's kind of worth mentioning because you will have patients who are on it, and they'll ask you about it. They'll ask what you think. So the first is tetrahydrocannabinol and its analogs. 11 patients received 2.5 milligrams of THC with improving symptoms for dementia. 40 patients on dronabinol showed improvements in BPSD symptoms. Case report of 2 patients taking nabilone found improved BPSD symptoms. Cannabinoids seem to be relatively safe, according to Timler and colleagues, and there's no increased rates of falls in 18 patients on oral THC. It seems pretty positive. So if your patients take it and it's helping them, they ask me about it, I'm not very surprised. But I also know that not a lot of physicians are quick to publish if their patient took THC and it didn't work too well. So I'm sure there are actually a lot of evidence out there saying it doesn't do too well. And also this is a topic that's very politically charged, at least in the States. I think the threshold for us to recommend it officially is also quite high. But it's certainly worth mentioning, and patients will ask you about it. Pimavanserin, it is FDA approved for psychosis and Parkinson's dementia. It's a 5-HT2A inverse agonist and antagonist. There was a phase 2 study that favored pimavanserin over placebo for agitation control in patients with Alzheimer's. Phase 3 study favored pimavanserin use for sustained reduction in psychotic symptoms in BPSD, but the FDA did reject it for BPSD psychosis. Certainly an agent of interest for psychosis in Lewy bodies and Parkinson's dementia. I will tell you, if you use it for Parkinson's dementia, it doesn't work right away. It does take some time. Yeah, insurance companies sometimes may not be that quick to approve, so that's another thing if you're working in the States. Gabapentin, potentially helpful, especially in the context of neuropathic pain. Supported by 14 case reports. The issue is it lacks defined dosage. It ranges from 200 to 3,600 milligrams daily. But I will tell you, if they have sciatica, if they have other pain problems that there's like a neuropathic component to it, this medication is something that I quickly will try to use because frequently, even if you use it at night, it actually can help them sleep better too because you're improving kind of the pain control. If they happen to have like restless leg syndrome or REM sleep disorder, which are very common in older adults, this medication can also concomitantly hit many of those things, so it can be really, really helpful. Of course, you want to be mindful about how their kidneys are working, what's the maximum dose that they can tolerate. If you give it at night and they tell you, Doc, I feel really, really sedated the next day, and they're only on 100 milligrams, that's a little bit weird. You could kind of make sure that they don't have other sleep disorders going on. But gabapentin is certainly a medication worth mentioning because of the evidence that's out there. So in conclusion, this algorithm is a guide. As you can see, as I'm going through it, there's kind of a lot of exceptions, or this is something you want to consider, this dementia subtype. So it's a guide. You have to tailor it to the conditions that your patient is experiencing. What are your patient's goals and belief? And base it off of that. Success relies on good communication, understanding your patient's priorities, and then you help the patients and guardians understand the risk and benefits of these medications. That's kind of our job. You list out the risk-benefit, you ultimately guide them to make the choice that they need. The last point is a really important one. Current guidelines advise antipsychotic trials to not exceed 4 weeks. And if medication is effective, you attempt to taper the medication at 4 months, unless the patient has previously failed medication tapering. So imagine you're the family, and it took you a year of waiting to see me, and you finally saw me. And we turned things around in a month or two, things are better. And then you say, well, the recommendation is that we should now taper. So we're gonna try that. That's actually a really, really tough conversation to have with the families. What you can do is you can try a small tapering. Let's say in this context of using the antipsychotic trial, you had started the antidepressant, and now you believe that the underlying depression or anxiety is working better. Then you created that space to perhaps attempt an antipsychotic taper, which clinically we call gradual dose reduction. You try it, it works, you keep pushing. You try it, it doesn't work, then you're a little bit in the gray zone, and what I do is I tell the patients, oh, maybe we tried it at winter time, which is frequently a harder time for older adults. We can maybe try again in spring of next year. You document the risks and benefits, and then you try again next year. And then if that fails again, good luck. This is a really, really hard field. You're just in a really tough spot. You just keep trying. Sometimes they might refuse to try because there's so much else going on. You document, and then you find the next opportunity to try again. So I think that's the end of my talk. Thank you for your time and coming to listen. I appreciate it.